So I welcome you all to this session of great speakers where we'll discuss about nitty-gritties of various retinal conditions. So firstly, we will invite a very accomplished speaker, Dr. Hamad Habib from Egypt. He is a surgeon par excellence and professor at Ain Shams University, Cairo. So I welcome Dr. Hamad Habib. Sir, are you here? So I think Dr. Hamad Habib is here. Dr. Vivek Dave is here. Dr. Falak?
I am here. Dr. Vivek is not there still.
Okay. Then
Dr. Sharif is there.
Dr. Sharif is there. Without wasting much time, if Dr. Vishal is there, I would like to ask him to invite Dr. Sharif.
Good evening, everybody. Thank you, Dr. Ashriya. And it gives me immense pleasure to be a part of this webinar, and furthermore pleasure to invite Dr. Sharif Sheta, vitreoretinal surgeon par excellence from the Cairo University and chairman of the Dar el Oyun Eye Hospital and Centers. He has had a very illustrious career both educationally and in his clinical side, and has served as professor at various universities across across the country of Egypt. Also has international experience at the Duke University Fellowship for VR, and has presented and been a member of Veil Vitrectomy, which is one of the most prestigious vitreoretinal surgical associations. So with no further ado, I would be very, very happy to invite Dr. Sharif to give his talk. Over to you, Dr. Sharif. So we can't hear you. We can see your presentation, sir.
Sir, please unmute yourself.
Now it's okay? Now you hear me?
Yes, sir.
Yes,
Perfect.
Sir, yes, sir. Yes.
Yes,
Okay.
perfect.
It's a quite pleasure to share in this ophthalmological meeting in this day of the World Eye Sight. And I'm very glad for the honorable invitation. The topic of my talk today will be about an interesting, hopefully interesting subject, which is retinal detachment, which is associated with PVR and hypotony. It's not uncommon that we see, especially in chronic and old cases of retinal detachment, PVR starts to develop and then hypotony. You know that hypotony can occur in several conditions, like after glaucoma surgery with the extreme shallowing of the anterior chamber. You can see forward rotation of the iris and ciliary body and choroidal detachment. Sometimes it is peripheral, sometimes it is more central. Sometimes it is extensive, and we call it the kissing choroidal, which is usually called the kiss of death, because this is an intolerable condition. You should interfere immediately, otherwise the kissing choroidal will adhere to each other, and eventually the eye will go into phthisis. Also, choroidal detachment can occur intraoperatively. If you do suprachoroidal infusion, if you miss that you penetrate the choroid completely and you start infusion before making sure that the cannula has entered the vitreous cavity, you can have an intraoperative choroidal detachment due to the suprachoroidal infusion. And I think it's very important that in these cases that you check the infusion cannula. you see this eye is mushy soft. It is very hypotenuse, it's pseudophakic. So before opening the infusion cannula, you just indent and make sure that the metallic part of the infusion cannula is inside the eye before opening the infusion. If it is not, you can enter an MVR blade or like a 23 gauge blade from the other side and just open the choroid above this infusion cannula before starting the infusion. Also, if the choroidal detachment and the hypotony persist, this is the soup that is very essential for the formation of PVR, which make the conditions very difficult to treat. This is an example of a patient that presented with choroidal detachment, as you can see here, on both sides, retinal detachment, and a chronic inferior break with rolled over edges. In this case, we start by making a core vitrectomy, just a core vitrectomy. After making sure that the infusion cannula is in the vitreous cavity, we remove the anterior traction on the flap of the break and make sure that we remove as much vitreous as possible, because the choroid actually indents the vitreous inside. So removing the vitreous in the central part is a bit easy. You make sure that you have detached the posterior hyaloid, because this is essential in this step. And after that, we do intravitreal injection of perfluorocarbon liquid. The idea of that liquid is to reattach the retina and flatten the choroidal. And by this, we can do shading of the vitreous base. You can see this flare and shine, Schrillian sign of fluid going, murky fluid going into the vitreous cavity due to the escape of fluid from the retinal tear into the vitreous cavity by the pushing forces of the perfluorocarbon liquid. You keep injecting perfluorocarbon liquid. I usually use the chandelier so that I have both hands. On the left hand, there is an extrusion needle, and on the right hand, the injection. And after reattaching the retina, we make laser photocoagulation to the edges of the retinal break. We shave the vitreous base, and usually in these cases of PVR and hypotony, I like to inject siliconide. This is another case of a chronic inferior retinal detachment with hypotony and PVR and intraretinal cyst, as you can see here. There is inferior retinal cyst, there is an epiretinal membrane and subretinal membranes due to the chronicity, and you can see the vitreous pigment, the pigmented RPE cells. These are chronic detachment that have been there for a long time, and you can see the source of the detachment are these tiny two little holes. They are very small holes. Still, they can cause a chronic inferior retinal detachment, and due to the chronicity, you can see demarcation lines, and you can see the intraretinal cyst. You should do all your effort to remove the posterior hyaloid. In this case, sometimes it is very difficult because this is a young patient, and sometimes it's time consuming, but it is an essential step to detach the posterior hyaloid. Otherwise, you'll be punished by recurrence of the retinal detachment after the disappearance of the tamponading material. You spend plenty of time. You can use triamcinolone stain to highlight the posterior hyaloid. I like to do it without triamcinolone stain to see what's behind, to see the vitreous, so that I'm making sure that my traction is not excessive to cause a retinal iatrogenic retinal break. And you keep removing the vitreous posterior hyaloid as far peripheral as possible, as you can see here. After that, after cleaning the vitreous, we do scleral indentation and shade the peripheral vitreous as much as we can. You keep persisting or removing the posterior hyaloid so that you make sure that, because sometimes there is more than one layer due to vitreous cases, there is more than one layer of the posterior hyaloid. So you should be patient and removing the layers of the posterior hyaloid till the retina gets freely mobile. After that, we inject the perfluorocarbon, as you can see. You can see here the demarcation line of the subretinal fibrotic bands due to the chronicity of the retinal detachment. We keep injecting, we inject inside the bubble so that not to make fish egg formation or bubbles, so that there is no escape of the perfluorocarbon into the subretinal space. And after that, we stop at this stage and we go to the periphery, shade the vitreous base, remove the fluid from the peripheral break, and then we augment injecting perfluorocarbon. At the end, we do laser photocoagulation to the retinal tears. Sometimes I like to do, in this case, a 360 laser photocoagulation. You can see here the subretinal bands that are away from the macula, so there is no need to address these subretinal membranes. And then I do direct perfluorocarbon silicone oil exchange. You can see that In the same time, the perfluoral bubble is getting smaller, and we're injecting silicone oil simultaneously, and the pressure is maintained. You can see that the pulsations of the optic disc mean that pressure is somewhat high. So I stop injecting and aspirate the last bubble of perfluorocarbon. And then this is the postoperative picture. This is a mosaic of the postoperative picture. You can see here the subretinal strands you can see, and the inferior retinal pathology. And you can see that the OCT showed the macula is completely attached, and this is the reflection of the posterior surface of the silicone oil bubble. This is another interesting case, a 25 years old young male who is highly myopic. The fellow eye was -13. He has Guillain-Barré syndrome with difficulty in walking and speaking. And that's why probably the detachment have been there for a long time. He has a history of diminution of vision few months ago. Vision at his presentation was hand motion, and the intraocular pressure was 4 millimeters of mercury. He had also had early posterior subcapsular lens opacity. Here you can see that the retina is highly elevated, and you can see the retina actually behind the posterior lens capsule. And this is the pigmentation on the vitreous cavity denoting the chronicity, and you can see here how soft the intraocular pressure is. In this case, before introducing your needle, I try to pressurize the eye by injecting fluid into the vitreous cavity so that you push the choroid to the global wall, so the penetration of the macrocannula is easy. Here you can see an egression of yellowish fluid. This is the suprachoroidal fluid. Here you can see that after injecting the cannula, I'm checking the cannula is not full through, and this is the brownish color of the choroid. So I go from the other hand with a 23 gauge needle and cut the choroid above the tip of the infusion cannula to make sure that the infusion cannula is free in the vitreous cavity before opening the infusion line. And you make a small air bubble to make sure that actually the fluid and the air bubble is inside the vitreous cavity. Then start to do vitrectomy, and vitrectomy is very tedious in this case, but vitreous is very sticky. You can see here how the detachment is chronic and the retina is folded over, probably from the chronicity and from the hypotony too. And you can see pigmented cells on the surface. We detach the posterior highlight, start injecting perfluorocarbon to reattach the central retina, and then go and work in the periphery. And make sure that you can see here the fiber optic light is penetrating the choroid, which is very thick. There are multiple superior breaks. You can see one of them here, and there are others here. You can see them now. And these stairs are responsible for the chronicity of the retinal detachment. We shave the vitreous base by using scleral indentation because I'm using chandelier. So I indent for myself and shave the vitreous base as much as possible. And you can see here that there is a lot of vitreous still in the periphery. But the beauty of the perfluorocarbon is that it delineates where is the vitreous. And so with a slow suction and high cutting, start to shave the vitreous in the shaving mode, not to cut the periphery of the retina. And you spend a lot of time shaving the vitreous base. You can see here the posterior capsular lens opacity. In these cases, I don't like to do cataract simultaneously. At the end of the surgery, you can see the retina is completely flat, and laser photocoagulation 2 or 3 rows around the multiple superior retinal breaks. And this is the postoperative picture. You can see here, these are the superior breaks delineated by the laser photocoagulation marks, and you can see the reflection of the silicone oil. And at the same time, you can see that the OCT shows complete reattachment. There is no subretinal fluid, and the macular architecture is back to normal. One thing that you should take care of that usually in this case, after injecting silicone oil in a choroidal detachment case, in the post-operative period, you see incomplete silicone film, because after a while, the choroidal detachment settles, and the vitreous cavity, now the silicone oil is not doing a complete support. Sometimes you have to go again after a couple of weeks or more to inject more silicone, because if you have an inferior retinal pathology, this will not be supported by the silicone oil bubble. So my take-home pits and pearls for this case is that you can use preoperative steroids only in preparation for surgery and not as a treatment of the hypotony. So don't wait for using pushing steroid, hoping for that the choroidal detachment will subside. It will not subside by medical treatment. It will subside by removing the pathological vitreous. Also, do not penetrate a soft eye with the microcannula. You should first pressurize the eye, either with intravitreal injection or using an anterior chamber maintainer. Also, you can use a long 6 millimeter microcannula to penetrate the choroid, to read the sclera and choroid, and you can do a vertical entry rather than oblique entry in the sclera so that you don't waste a lot of millimeters traversing the sclera. Also, check for the clear metallic tip of the microcannula in the vitreous cavity before opening the infusion. After doing core vitrectomy, use perfluorocarbon to flatten the choroidals and shape the vitreous base. I usually use silicone oil as a tamponade in these cases to stabilize the blood-ocular barrier and prevent early recurrence due to the PVR process. Be ready to deal with the incomplete silicone oil fill after subsidence of the choroidals. And I usually end the procedure by using subtenon long-acting steroid for the uveitic part of the inflammatory part at the conclusion of surgery. If the patient has concomitant cataract, I'd like to defer the cataract till the time of silicone oil removal because adding phacoemulsification at the same time will increase the uveal irritation and probably increase the PVR process. And thank you very much.
Thank you, Dr. Sharif, for this wonderful presentation and touching on all those difficult retinal detachment scenarios which we face, and also the realistic challenges we face as VR surgeons in securing the infusion, separating the vitreous, especially in the younger age group, and using PFCL very intelligently to ensure that our vitrectomy is more complete and providing much better anatomical and functional results. I would ask, could we have the questions at the end, or could we take some questions now? Do we have the other speakers ready, Dr. Ashray?
Maybe we can take one question, Vishal, and move on with Dr. Vivek.
Sure. I just had a question for Dr. Sharif. Do you use any injectable systemic steroids in patients with choroidal detachments? And at the end of the surgeries, do you drain the choroidal so that there's no underfill of silicone oil? Because that's a big problem, especially in inferior pathologies, like you rightly said. Do you attempt to drain the choroidals after settling the retina or prior to settling the retina in your cases? And do you use systemic IV steroids in case you're having a choroidal detachment?
I usually use preoperative steroids just in preparation for surgery. So if I have a patient that's scheduled for surgery, I start systemic steroid just till I do the surgery. I don't use post-operative steroids. I use subtenon steroid at the conclusion of surgery, but not systemic steroids. And I don't think you should wait by pushing steroid, hoping for the uveal irritation to subside and the choroidal to flatten before going to surgery, because they will not. They will not unless you remove the pathological vitreous. So it's a preoperative push of steroids just in preparation for surgery. The second question regarding draining the choroidal, usually if you remove the vitreous and use perfluorocarbon, usually it flattens the choroidal. It is not complete reattachment of the choroid. If the choroid with the perfluorocarbon is still elevated so that there is no more room for the tamponading material, I drain the choroidals. And the way I drain the choroidal is that I withdraw the infusion cannula a bit. And this is usually sufficient to drain the choroidal. So remember that there is a suprachoroidal fluid. And during withdrawal of the infusion cannula, I don't withdraw it completely outside. I just gradually withdraw it to go into the suprachoroidal space, and in the same time pushing like air tamponade or pushing fluid so that the pressure is high inside the vitreous cavity and will push the residual part of the suprachoroidal fluid. But you never gain full reattachment of the choroid. There is always a shallow film of suprachoroidal fluid that makes the silicone oil tamponade after a while insufficient. So the incomplete fill is a usual occurrence, and you should deal with this problem. If the pathology in the retina is superior, the incomplete fill will not be that bad. But if you have an inferior retinal pathology, then you should be forced to do reinforcement of the silicone oil in a 2 weeks' time.
Great points made. Thank you, Dr. Sharif, for this.
You're welcome.
Thank you, Dr. Sharif. Can we have Dr. Devendra Salak to moderate the next speaker, Dr. Vivek?
Yeah, thank you, Dr. Ashray. It's my pleasure to call upon our next speaker, Dr. Vivek Dave. He is vitreoretina consultant at LV Prasad Eye Institute, Hyderabad. He's a great surgeon par excellence, great mentor. And to his credit, he has more than 120 peer-reviewed publications. Without wasting much time, I would like to invite Dr. Vivek Dave to speak on the topic of surgical tips for optimizing endophthalmitis management.
Thank you, Devendra. Good evening, everyone. I hope I'm audible clearly, Devendra.
Yes, you are audible, sir.
Thank you. Thank you for inviting me for this wonderful program. I have a difficult job of following Dr. Sharif Shetta, but here it goes. Let me try. So I'll be speaking on surgical scenarios in endophthalmitis, some tips, some tricks, and approaches for different elements of surgery in endophthalmitis. So when we say endophthalmitis, these are, often the pictures that come to our mind. Each case is unique. Each case requires a different surgical approach to have an optimum outcome. If you look at literature, you see there's a plethora of material on intravitreal injections in endophthalmitis. Which thing you inject, what is the concentration, what is the latest antibiotic, what is the resistance pattern. But if you try to really dig deep, there will be hardly anything which will tell you how you approach these situations surgically. Often these cases are relegated towards the end of your surgical list. They are often done by your team members who are relatively junior, and it could be towards the fag end of the day. So this makes it very important for us to understand certain things that one needs to know to approach these cases and get the best possible results. So while I've been given the topic of 10 tips and tricks, I will try to put across different objective points, each explained with a video. So we may not be able to get through 10 things, but let us see whatever we can in the time allocated. I'll try to split each point into a surgical case scenario, the rationale of the operative intervention, a surgical video to explain the point, and then a take-home tip or a take-home message. So first one, this is the commonest scenario that we tend to face in our clinics. This is something that as cataract surgeons, we don't want to see, an endophthalmitis post-cataract surgery. Classic presentation of vision decrease post-op. You see corneal edema, you see a hypopion, you see a B scan, which shows the vitreous cavity, which is full of exudates. So the approach here ideally should be you take endophthalmitis like, say, an abscess cavity from general surgery. So in general surgery, if you see an abscess, you clear an abscess. There is no two ways about it. Similarly, in today's time, most practices have moved away from doing just biopsies or just intravitreal injections and actually attempting to do a complete pars vena vitrectomy as far as possible. When I say a complete vitrectomy, I would mean to try and clear off the vitreous till the periphery, till the extent you are comfortable surgically and till the extent to which visualization permits you. And as and when possible, if possible, in each case, I think with today's instrumentation, one should attempt to induce a careful PVD. And if you are able to detach that posterior hyaloid of the retina, nothing like it, that ensures that you are able to clear the vitreous cavity in the best possible way. So just a surgical video explaining what I said. Falak, can you confirm that the video is playing well for you?
Yes, playing well.
All right. So as you can see here, a posterior vitreous detachment has been induced. So what this ensures is now when you put the cutter on, all this vitreous very quickly comes to your probe and clears out effectively. Hence, it allows you to also have a good look of the retina on table and gives you an idea whether you're dealing with a retinal abscess or if you're dealing with any other retinal pathology that requires extra attention, which you may miss if a posterior skirt of vitreous is left behind. So this is how this case behaved post-op because we were able to do a good PVD. We achieved a good clearance and everything settled well. So tip one, wherever visualization permits, clear the vitreous cavity. PVD induction when done in a controlled manner is safe and effective. It deloads the vitreous cavity and allows inspection of the retina on table, which gives you a good prognostication. Let's go to the second thing, AC exudates. Every now and then we will see case of endophthalmitis that have a lot of AC exudates. One to your left is a photograph with a repaired corneal tear and post-trauma endophthalmitis with AC exudates. One to the right is something where the SICS cataract tunnel actually melted off. You have the iris which is prolapsing, patient going into an endophthalmitis and having these AC exudates. So you see these exudates in the anterior chamber when the inflammation is very high, or the patient is a known case of diabetes mellitus, or iris manipulation has occurred, or a lot of iris trauma has occurred in the precedent event to the endophthalmitis. This again interferes with posterior visualization. If you can salvage or take out all these exudates, you could have a good source of a microbiology sample. And once removed, it also allows the pupil to open up well. And hence, in my book, if visualization permits, you should attempt to remove the AC exudates well. So let's see this particular case, how we deal with it. So we take a 26 gauge needle, aspirate it a little so that it engages one edge of the AC exudate, and then slowly dislodge it off the iris surface. So when you do that, you will see a good cleavage plane occurs between the exudates and the underlying iris, which then can be enhanced using a viscoelastic injection. And then the entire exudative membrane can be completely separated out. Once it is separated out from the same side port incision by just enlarging it a bit, you can actually put in your limbs forceps and slowly tease out all the exudates from the anterior chamber. And my approach is there and then on table, take a chocolate agar plate and just plate it and send it to microbiology. So this is how the case ended with completely pristine anterior chamber in the post-op. Thus, AC membranes are easily cleaved off the underlying iris. The trick is to identify the dissection plane. A combination of a 26 gauge needle, visco cannula, and lens forceps can be used. And once all the exudates are collected, best approach is to directly plate them on an agar plate and send them to microbiology. Third situation is a lens abscess. To your left, you see a deep lens abscess, which has come in from an endogenous endophthalmitis. To your right, you see a relatively superior lens abscess, which has come from an entry wound in a post-trauma endophthalmitis. So what exactly do we mean by lens abscess? It's an infectious clinical presentation comprising of purulent material in the substance of the crystalline lens. And it could either be a complete or a focal yellowish creamy lesion at presentation, could be deep or superficial, as we saw in the photographs. And ideally, it requires lensectomy for appropriate clearance of the infectious focus. If the patient is a very aged patient, then you can even do a small incision cataract surgery. But what I mean to say is, it is important that the entire lens abscess, the entire lens material along with the capsule is removed, because that is the nidus of infection. This is what we also published recently, showing that whenever the lens abscess is completely taken out, you have very good results of resolution in the endophthalmitis. So we will look at one such situation. You can see from the side port, the lens abscess is being approached. Whatever is the purulent material is being teased off and is then sent to microbiology, just like the AC exudates. And once that has been done, the rest of the lens matter, including the complete capsule, is completely cleared out. And that ensures that the entire focus of infection is removed. There's a take-home tip is that location of the abscess will depend upon the mode of occurrence, deep if endogenous, superficial if exogenous. The exudates classically look connected to the crystalline lens, and a complete lensectomy is the key for best surgical outcomes. Now going to endophthalmitis with retained intraocular foreign bodies. As you can see here, you have a repaired corneal tear, which was the entry wound, a hypopion, endophthalmitis, and a CT scan showing a retained intraocular foreign body. Now, this is something that we all know and we all follow in our practices, that whenever you have a retained foreign body in an endophthalmitis, it requires a prompt vitrectomy. So again, just injection or just taking a sample would not have a role unless you don't have visualization and you don't have an armamentarium to bypass the opacity. This is also important because it avoids siderosis and worsening of endophthalmitis in the follow-up period. It's the same patient who had the lens abscess, and if we play that video further after the lens abscess has been tackled, we see there is this admixture of exudates and vitreous hemorrhage in the posterior cavity. This again is sine qua non of trauma, because an infected case of trauma will also have hemorrhage which occurs due to trauma. So it's important to differentiate just vitreous hemorrhage with an admixture of hemorrhage and exudates. So here, as we clear the vitreous cavity, we can stabilize the posterior pole in case there is active bleeding seen. We can stabilize the posterior pole with a perfluorocarbon liquid. And as you can see here, the foreign body is tackled with a magnet. Often, most of these foreign bodies are metallic and highly amenable to removal using a magnet. And this is how we tackle these cases with concurrent endophthalmitis and intraocular foreign bodies. Thus, the next step is that the IOFBs are best removed promptly in these cases with endo. And in case of concurrent lens abscess, as we saw, a lensectomy allows for complete removal of the nidus of focus And also, because you have done a lensectomy, it now gives you one path through which the IOFD can be removed under complete visualization through the anterior route, as against removing it from one of the ports, where the last step of removal becomes something like a blind procedure. Now let's go to a delayed onset or a low-grade endophthalmitis. If you see to your left, this is a case of a delayed onset endophthalmitis where a patient has been operated with a cataract surgery many months ago and now comes with repeat episodes of redness and pain. And you can see all of these keratic precipitates studded all over the corneal endothelium. So this is one presentation. Now this is the second presentation. The arrow is pointing to a creamy small lesion which is present in the posterior capsule. Again, an eye which was operated a few months ago, on and off is coming with redness. So these are common presentations of a delayed onset endophthalmitis. So signs and symptoms, as you see, are indolent. Medical management alone can often cause a recurrent inflammation. In my practice, the best approach in my hands is to have an IOL explanted as early as possible after initiating a dialogue with the patient. The patients are often sentimental about the intraocular lens, so it is important to explain to them the fact that the IOL is often a nidus in such cases, and if it comes out, it is likely to achieve a greater and quicker resolution of the endophthalmitis. We have also published this information comparing presentations and outcomes of delayed onset endophthalmitis managed with or without intraocular explantation, where we saw that the subset with explantation does better, and also primary explantation versus deferred explantation, where we again saw that primary explantation does better. Hence, for most of us in our institute, in our practice, we look at explanting the lens earlier than later. Again, a small video showing the same. You make your classic 3 ports and then make an SICS tunnel, which is used for cataract surgery. And through that, just tease out the intraocular lens and the capsular bag. And again, just like we spoke in the lens abscess, you pick this up and immediately and directly plate it on a chocolate agar plate. So as you can see, often you would see a growth around the IOL, which would be indicative of the incriminant organism which has caused the infection. So the next take-home tip is IOL explantation is the best approach for delayed onset and low-grade endophthalmitis. Removal along with the capsule ensures complete removal of the nidus of infection. And these cases do very well later with a glued IOL few months down the line. Falak, please let me know if I run out of time. Next, we go to endogenous endophthalmitis with macular abscesses. As you are seeing in this case, an immunocompromised patient with a macular abscess on both the maculae. The corresponding OCT again showing a lot of posterior inflammation, retinal edema, and confirming the abscesses. Now here the infection is deep-seated, requires a complete vitrectomy. But what is important is if you take a classic vitreous biopsy, which we routinely do, which is behind the patellar fossa, then we may not really get too much of a good result microbiologically because the infection is not there. The most infected part is deep in the eye. So this is again something that we published last year where we compared the culture positivity rates of a deep vitreous biopsy taken under air vis-a-vis conventional anterior vitreous biopsies that we do in post-surgical or post-trauma endophthalmitis. And what we found is when we take a deep biopsy, the yield increases 200 times. So that definitely tells you that you should take a deep biopsy in such cases. Now, how do we take a deep biopsy in such cases? This is a demonstrative video. Instead of infusion line, you attach air and start your vitrectomy. So what happens is air keeps coming in, ensures that the globe tonicity is maintained. At the same time, the vitreous is not diluted. So continue your vitrectomy till you reach towards the posterior pole. And once you have reached the posterior pole and have come very close to the abscess, you can then carefully and slowly induce the posterior hyaloid detachment, like I explained in the first video. This ensures that you're able to get a good vitrectomy in a complete manner. Here you can see the Weiss ring has got created. And it is at this point that the sister connects a 2cc syringe behind the cutter, and all this material is then collected and sent for microbiology. So this ensures that you are able to collect undiluted and the most infected part of the lesion inside the eye. And this is how the patient did down the line during follow. So the next tip is take a deep biopsy in endogenous endophthalmitis, take as close to a visible lesion as possible. And to ensure this, You do this under air infusion so that you get an undiluted deep sample. We then go to a special subset of endogenous endophthalmitis, which is a submacular abscess. This again was a patient who was severely immunocompromised and came with loss of vision. And here you see a small yellowish lesion right there on the posterior pole with some amount of hemorrhages. So clinically, most of us would agree that this, in the given clinical scenario, would be an infectious pathology. The corresponding OCT shows you a nice demarcated hyperreflective lesion in the subretinal space with some subretinal fluid. Now, in this case, the vitreous cavity, like you saw from the fundus photograph and the OCT, is completely quiet. So if you take a sample from the vitreous cavity, you are likely to get zilch. So what is important is you need to take the sample from where you are seeing the abscess, which is in the submacular space. So how do you do that? Again, you need to do your core vitrectomy. Once it is done, induce your PVD and ensure that the whole vitrectomy is complete. Once it is complete, you need to go to a 41 gauge needle and then puncture this lesion as seen in the video, and keep looking at the golden tip of the needle, and you will see yellowish material rising up the tip. So the sample has got aspirated directly from the infected focus. Now, this is something that can be directly plated on the blood agar or chocolate agar plate. And this is what we saw. We saw candida, and this patient was appropriately treated, and the entire lesion resolved. So the next take-home tip is that a 41 gauge needle can be safely used to aspirate from a subretinal abscess cavity. Often you have to suspect candida etiology in such cases. Vitreous biopsy in these cases is invariably sterile. Hence, it is very important to pick up the infected sample from the area where it is maximally infected, which is the subretinal abscess. Now, this is the last couple of slides. Endophthalmitis with the severe corneal involvement. You see here a young girl who was hit by an iron nail and presented to us with a repaired corneal tear with tissue adhesive elsewhere and an immune stromal infiltrate on the cornea, which did not allow a good posterior segment visualization. So in the emergency, a vitreous biopsy was taken, intravitreal empiric antibiotics were injected, and day 2, we saw Enterobacter species grow up on chocolate agar, which was multi-drug resistant. So what we had here was a post-trauma etiology, a gram-negative organism, a young patient, no posterior segment view. So everything that tells you that you should go ahead and clear the vitreous cavity, but with this given corneal involvement, posterior segment visualization would not be adequate. So these are the cases which are most appropriately managed with the endoscopic approach. As you see here, I put in an endoscope and I get a pristine view of the vitreous cavity, very clear view of all the exudates. And slowly and surely, all the exudates can be cleared right down up to the retina. As you will see, once the exudates are cleared, we are able to see the retinal surface. You see some amount of cystoid macular edema there. And then you inject appropriate antibiotics as per the antibiotic sensitivity profile. And this is what you land with. So the original part or original area of injury you can see is scarred, but the entire stromal ring has cleared out. So suppose you would have attempted this procedure conventionally, either you would not have been able to do a vitrectomy, or you would have fallen back on a keratoplasty or a keratoprosthesis. If you do that, you would not be able to get this natural corneal clearance because you would have then replaced the corneal surface. Thus, the take-home tip here is corneal haze in case of endophthalmitis in many cases is often temporary. And endoscopy allows a posterior segment clearance with adequate visualization in spite of anterior segment haze, avoiding unnecessary keratoplasties and keratoprosthesis in such cases, and thus allowing the host cornea an opportunity to clear out naturally. This is also something that we published and showed that this really has great benefit. So in conclusion, surgical implications of endophthalmitis are varied. Each situation requires a tailor-made approach for optimal outcomes. And I hope for the audience, all these videos that I showed would have some tips or tricks that they can take with them to their operating room. Thank you very much for your patient care.
Yeah, thank you, Dr. Vivek. That was a very enlightening talk. As we are already running behind time, I would like Dr. Ashray to call upon our next speaker. We can take questions at the end if time permits.
Thank you, Dr. Vivek. Such an enlightening video. And we all know what a great surgeon you are. And I would like to take this opportunity to invite Dr. Ahmad Habib, who missed on the first talk. So if he's available, Dr. Habib.
Yes, hello.
Hello. Welcome, sir. I would, without wasting much time, we will go ahead with the talk. Can you share your slides?
So I'm trying now. So is it okay?
Yeah, absolutely, sir.
So my talk is about submacular hemorrhage, the straightforward and otherwise. So the normal steps of the submacular hemorrhage surgery is to use the TPA, and the gist of it is to inject TPA under the retina to emulsify the clot and to be absorbed. So I use the 41 gauge needle. I like to use the short one, the green one, so as to see it and to pierce the valve cannula. And I like, as you saw, to bend it a little bit to be tangential to the retina, to be able to inject it better in a better way and not to pierce the RPE, just to enter the subretinal area and to inject the TPA. And you can inject it into multiple points to get the fluid centered under the posterior pole. A nice trick is to sometimes do FAX to pull the fluid into the posterior pole to reach the subfoveal area, because sometimes the injected fluid doesn't go where you want to be, where you want it to be, but just you do FAX and it will go to the most dependent part, which is the posterior pole. This is another case where I remove some clots over the retina and inject in multiple points also. You don't have to inject saline. You can inject 0.2 cc's to 0.3 cc's of TPA, and this will just be enough. And you inject air. Actually, the subretinal injection of air is a controversial point because, as you saw, the injection of air comes with a force that could invite a macular hole opening. So, as if you feel it's not safe, you can skip this point, this step. The idea of the air is to push the subretinal hemorrhage downwards away from the fovea. But as you can, as I said, you can skip this area. So that's the normal steps of the submacular hemorrhage surgery. But through hardships, we learn more actually than the straightforward cases. So I would like to share another complicated case, a traumatic submacular hemorrhage case, which went out of the norm, from which I learned a lot, and I hope you learned from it as I did. So our patient is a young female, 23 years old, with a direct trauma to the eye by a tennis ball 3 days prior. Submacular hemorrhage with vitreous hemorrhage bands was the picture, and as you can see, some lacerations of the retina, and actually it looks like that there could be a choroidal rupture, and the patient was counseled for that. So I started the case normally with PVD and removing the vitreous and removing some of the clots. And as you can see, there is some active bleeding sites. And I wasn't sure if these retinal lacerations were through and through, but while flushing the air, there was a small through and through break in these lacerations. But I decided to continue as planned, and as you can see, I bent this. This is a nice trick that makes sure that you enter into the subretinal space, and I injected a good amount of TPA until I saw this egress of the fluid through this small hole. So what to do next? Do we continue the subretinal air injection? The answer is no, because I learned the hard way that if I inject the subretinal air in the presence of a macular hole or an open break, it stays open and it enlarges and stays open that way, and you will need another surgery to close it. So you deal with it. If it's a macular hole, you deal with it with an inverted flap, or if it is a hole that is away from the fovea, you just leave it and you don't inject air. That's what I decided then and there. And you aspirate from the break. I also don't recommend to aspirate from the break because it increases the size of the break, and you just emulsify this clot with the TPA, and this would be okay. So I decided to end the case, and I was just finishing up and removing the peripheral vitreous, and I decided to close. But as perfectionist that I am, I tried to remove the small bits of hemorrhage that was there just to be neat. But this actually was a mistake, because hemorrhage increased a lot, and active bleeding that couldn't be stopped occurred. So the case went sour. And what do you think what happened? I think what happened was that the clot was emulsified with the TPA, and I removed the only clot that was stopping the bleeding by aspirating by the flute needle. So the bleeding increased, and there was an active bleeding, and there was a collection of a large amount of blood under the retina. So the TPA is already injected now. Do I leave it and close? Do I drain from the original break? Do I drain from another retinotomy? And what about the original clot, which I entered for in the first place? So the next steps wasn't planned, so let's learn with each other. So I tried first to aspirate by the 41 gauge needle and the 30 gauge cannula, but it didn't aspirate this blood. So I did a retinotomy and removed the blood, and tried to remove from the original break. But as you can see, the clot subfoveal was still there, and that's what I was entering for. This is I used the ingenuity to actually delineate the clot, and the clot was actually there under the fovea, and it didn't emulsify or move. So I had to do something, because this was the actual reason I entered. So I had to enter under the retina and remove this clot. Maybe in hindsight, I wouldn't do this. I would touch the whole retina and reflect it and remove it from under the fovea. But this is what I did. But fortunately, the retina remained flat. She's now 9 months after. The best vision acuity was 0.3. The visible annoying scotoma was there, and the central vision was preserved. So my tips and tricks is to check the fluid flow through the 41 gauge cannula. Use a short cannula to be able to insert it better and easier through the valve cannula. There's a type which is green that you can see better. I usually bend the tip to be tangential to the retina for ease of injection. I inject only TPA and not. I used to inject saline, but it's not. I know now it's not necessary, because the 0.2 to 0.3 cc's is just enough. You inject in multiple sites to get the TPA where you want it to be. Subretinal air injection is a step that can be skipped. And if you fear that it would cause a macular hole, don't do it. And if you use it, just press very finely on the injection. So because the injection of air is forceful and a little bit surprising. ILM removal is not actually recommended because it may invite a macular hole formation, and the TPA can increase the bleeding if there is an active source or a clot. If there is a clot, do not remove it. So it would increase also the bleeding. So do not fiddle with clots and be gentle. Thank you.
Thank you, sir. That was quite a challenging scenario, and it was excellent display of surgical craftsmanship. So without wasting any more time, we'll take the questions at the last if time permits. I would request Dr. Sharath Hegde to take over and invite the next speaker, Dr. Dinesh Talwar.
Thanks, Ashraya. It's a privilege to introduce Dr. Dinesh Talwar, who is a senior vitreoretinal surgeon from the Center of Sight, New Delhi. He is alumnus of All India Institute of Medical Science. He has done this, he has special interest in the medical and surgical management of endophthalmitis. And he also has a lot of academic thing where he has edited more than 2 books. He has written more than 17 chapters and published more than 50 articles. He is also a receiver multiple awards like Mohammad Daud Kaur Oration Award from the SARC Academy and R.N. Roy Memorial Best Paper Award. Without wasting much time, I request Dr. Dinesh to start his presentation. Can you unmute yourself, Dr. Dinesh?
I'm sorry, what did you say?
No, just please can you start your presentation? Sir?
Yeah. Also, I'm just sharing my presentation. Can you see it? Sir?
Yes, sir. We need it in a full screen, if possible.
Yeah, I'm just doing that. Yeah. Okay. So without further ado, let's come to management of myopic retinal detachment. The reason I wanted to discuss different paradigms for different situations is because even within high myopia, it's not one situation that you're dealing with. This is my disclaimer and my financial disclosure, which is not relevant to this particular talk. Now, basically, when you have a patient with a high myopia, this could be high myopia with a retinal detachment with peripheral breaks or say lattice with holes. So these are the associated posterior staphyloma may or may not be there. And then you have 3 other categories, all of which are associated with posterior staphyloma, which include a myopic retinoschisis, which could be foveal or parafoveal, or a myopic retinoschisis with a foveal retinal detachment, or a retinal detachment involving the entire posterior pole. And lastly, you could have a myopic retinoschisis with a foveal or posterior pole retinal detachment with a macular hole. Now, the importance of knowing whether there's a posterior staphyloma or not is because if you look at this, once you have a posterior staphyloma, you have added traction on the, not only added traction from the vitreous and because of this taut hyaloid, but also because once the retina is detached, there is a taut ILM, internal limiting membrane, which is creating a relative shortening of the retina. It's going to prevent the retina from settling. So this ILM, which is the innermost layer of the retina, is 1.5 micrometer thick in the peripheral foveal retina, thickest in this region. And not only will this cause the retina to not settle, it also serves as a scaffold for cellular proliferation of myofibroblasts, fibrocytes, and RPE cells. Now, the important thing to remember is that when you come to traction-induced maculopathy, this is there in 1/3 of highly myopic eyes with a posterior staphyloma. And it goes from the stages of foveal retinoschisis to formation of a lamellar or full thickness hole to finally a retinal detachment in the posterior pole and then going into the periphery. The important things to keep in mind when you're dealing with a retinal detachment with high myopia is, one, is there a history of recent visual loss localized to the posterior, in RD localized to the posterior pole? Because sometimes this may be just there for a long time without really affecting vision too much. So I would touch these cases only when there's a significant visual deterioration with a visual acuity less than 618 in cases which have a localized posterior RD. If the vision is say 612 or better, it's better not to touch these eyes, especially when there's a lot of retinal degeneration in these cases. The second thing to look for is whether there's schisis with or without a macular hole. And lastly, what will make a difference to how you manage depends on whether there's a posterior staphyloma and how much is the RP atrophy in the macular area. Eyes which have an RD without a posterior staphyloma, only peripheral breaks are there anterior to the equator, patient is phakic. All you need to do is a scleral buckling. You don't need to do anything else for these patients. Eyes which have breaks which are posterior to the equator, or if they cause a bullous RD or there's a lot of hypotony, vitreoretinal surgery is the way to go. And the important thing to remember here is there is a layer of vitreous schisis with remnants of the cortical vitreous adherent to the retinal surface, which need to be removed. And this could be an entire sheet, or this could be some localized areas. And I'm going to show that just now. In these cases, you do not need an ILM peeling. The ILM peeling is needed when you have a posterior staphyloma. Here, you not only remove the layer of vitreous schisis, but you also need to do an ILM peeling till the edge of the staphyloma and beyond. Now, I'll just show you the videos which regarding the same, but this is to show the evolution of one patient who started out with a macular hole only. Vision was very good. We did not touch 612 vision he had. Then became a myopic macular hole with a schisis. His vision was still maintained, but finally he developed a detachment and was taken up for surgery, and following via surgery settled down. Now, this is to show you a patient who has vitreous schisis with cortical remnants. And the best way to see these is by using a tricot or kinocot, whatever you may call it. You can see over here, you'll first remove all the extra tricot. You'll find there are a few crystals left. Start stroking it gently with a diamond dusted membrane scratcher, and you find these areas which are there, which are going to actually cause redetachment if you don't take care of them in the first surgery. The second one is where there is a complete sheet. Now look again, we remove these extra crystals of tricot. This is the best way to remove it. Now you remove with a diamond dusted, it will slowly come off. And here you can see that there is a complete sheet. This sheet, if it's not removed, will virtually ensure that you'll get an initial settlement and the retina will detach later on again. So this has to be removed in all cases where there is a high myopia with a retinal detachment when you're doing a vitreous surgery. Now we come to the patients who you remove the vitreous schisis, and then you remove any ERM or ILM peeling only when there's a posterior staphyloma. This was one of the surgeries we did in our early days when we actually, frankly speaking, did not have a staphyloma, and we still went ahead and did an ILM peeling. I'm only showing this to show you why ILM peeling, PFCL can help you. That's a tip for you. It can help you if you're having a difficulty in doing ILM peeling. Once you maze the flap of the ILM, and you find that the retinal detachment is pulling too much, as you see in this case, you may find it easier to put a little bit of PFCL in this case. And this is what we've done here. And once you put a little bit of PFCL, you get a counter traction, which makes it very easy to now remove the rest of the ILM. Of course, I again repeat, in this particular case, it was not necessary because there was no posterior staphyloma. But because of the PFCL, we were able to remove this ILM very easily. And I always move towards the foveal center. Don't pull away from the fovea because especially if there's a macular hole, you can get an increase in that. But this is where sometimes you can have a problem in a patient with a macular hole. This patient had a macular hole, as you can see in his pre-op OCT, with a detachment, but also very severe degeneration of the RP. And we made these small flaps. I used the 25 gauge MVR to create very small flaps in the ILM, and then thought I will use the PFCL to give me the counter traction. And lo and behold, what happens? You put the PFCL and there is so much RP atrophy, I lose the contrast altogether. I was forced to again remove the PFCL. And then after that, the contrast became better. I will create larger flaps. As you will see, now these are large flaps being created in the ILM so that the visualization becomes easier. And then to make sure I only move towards the fovea, don't want to go away from the fovea. I've again now put the PFCL. Now, because the flaps are big, I'm able to visualize it. And now you can see carefully, I am removing this flap. Put enough, I can see the flap. So it's easier for me to move this. Move towards the fovea, inferotemporal quadrant, and then circumferentially, not beyond the circumferential area, will not go. I will not try to go too much in the periphery. I have another flap in the upper part, which I'm now again moving. And try to make sure you don't lose this flap, because once you lose the flap, you lose the visualization again. So I'm trying to make sure that I can take it out in one go. And keeping this visualization intact, I go all around circumferentially and then towards the foveal center and remove this. And this worked well. Now, when you are doing the vitreous iris removal, be careful. There is one problem that you can sometimes face, and you'll see that very quickly here. You see, I'm removing this sheet, and as I go remove it from the center and move. Incidentally, membrane forceps don't work very well for picking this up. And look here what happened. This was the edge of the staphyloma. Without visualization, never go into any area. I made the mistake of missing that edge and hit the staphyloma edge, got a break there with a hemorrhage, which had to be managed. And managing breaks at the edge of a staphyloma can be very difficult. So better to prevent this by doing the whole procedure under complete visualization. Don't let anything go under without visualization. Ladies and gentlemen, basically ILM peeling helps a lot for bridging the macular hole because it allows gliding of the retina, increases the plasticity of the retina. The retina now follows the posterior staphyloma. So this is needed. The ILM peeling is needed for the posterior staphyloma cases. And of course, it also allows recognition of anything you've left of the vitreoschitic layer, though the best way to remove the vitreoschitic layer still, as I maintain, is by using triamcinolone. RD with myopic maculopathy or high myopia with RD anyway are all challenging cases. Patient selection and patient paradigm of management are both important. But if you follow the right paradigm, the surgery is rewarding. Results are very gratifying. Thank you very much, ladies and gentlemen.
Thanks, Dr. Dinesh Talwar. It's a very nice and very important points for the young retina surgeons to know during the myopic macular traction and myopic retinal detachment surgery. Dr. Ashray, do you have time for questions?
I think we are running out of time, but and the next set of speakers are already waiting. So just to thank everyone in the panel, just wanted to reiterate all the points which our pregnant speakers emphasized. Dr. Sharif very beautifully showed that it is very important to treat the cause and not to wait too much for the choroidal detachment to settle by just loading the steroids. He very beautifully showed that we have to, before entering into the putting the trocar, you need to form it. That's a very important tip. So again, Dr. Vivek Dave showed us that each end of comes with the various other complications and necessities. So each approach needs to be tailor-made. And again, Dr. Ahmad Habib showed us the usefulness of TPA and how it can be safely and effectively used in submacular hemorrhage, and all the nitty-gritties of injecting under the macula. And again, Dr. Dinesh sir very beautifully showed how vitreous iris should not be neglected. Otherwise, we are in for a recurrent detachment post-surgery. So I think all these points have only enriched us, and I would really thank each and everyone in the panel. And
Ashray, one question I'd like to ask Dr. Habib. What was the concentration of the TPA they used for subretinal use?
So it's actually 12.5 mics in a cc. Actually, the safe dose is under 50 micrograms. So I only inject 0.2 to 0.3. I only put inside my syringe 0.2 to 0.3, not more.
Yeah, so it's important to dilute the TPA before use. That's the reason. Yeah.
So a question for you, sir. So sometimes the axis length is too long to safely or to easily reach the posterior pole. Do you have any?
So frankly speaking, you will realize most of the time this problem occurs because when you're using the biome or the recite, it's actually the shaft of the instrument which hits the lens, and that's why it doesn't go deep enough. So one of the easiest things you can do is actually to use the Lander's lens, self-retaining or assistant viewing. Either way, assistant help. Both of them will actually improve your ability to take care of most of these high myomes. In the last category, those are which are more than 33 millimeters, which is very rare, but very rarely you can get a 33 millimeter eye. There, remove the trocars. If you remove the trocars, you get another 2 to 3 millimeters. So if the first step, just shift from the wide field, the biome or the recite to the Lander's lens, and you will find your problem will disappear. And also, if still it is there, the last thing you can do is remove the trocars and use the instruments without the trocars. It will still work.
Sometimes you also use. I'm sorry.
Sir, just I wanted to add in the paper from Bascom Palmer, I guess they have also showed to visualize the pars plana and go up to 6 mm from the limbus. And
yeah, but believe me, you won't need that except in an eye which is more than 35 millimeters, and that's a very, very, very rare situation.
Sometimes I use the transillumination from the endolite from inside and put the other trocar at about 5 to 0.5 to 7. Thank you.
Thank you, everyone. I think it was hour of excellent learning. I would invite the next set of speakers to take over the session. Thank you.
Thank you.
Hello. It was a really informative and wonderful session, and I'm sure the session to follow is going to be the same. It's my pleasure to invite our first speaker. We'll jump in directly because we're a little behind schedule. Our first speaker in this session is Dr. Stratos Gotzaridis. I think he has joined us. It's my pleasure to give him a brief introduction. He has graduated from the Medical School of Aristotle University of Thessaloniki and completed his military service and thereafter trained in ophthalmology. He has numerous fellowships to his credit. He has done a 1-year fellowship in uveitis and inflammatory diseases at Croydon University Hospital, London, a 1-year fellowship in VR surgery at Southampton University Hospital, a fellowship in vitreoretinal surgery at Moorfields Eye Hospital, and others of note as well, including at the Mass Eye and Ear Infirmary in Boston, USA. He has been practicing as a vitreoretinal surgeon in Athens since July 2001 and mainly focuses on surgical retinal problems, medical diseases of the retina, and uveitis. It's a real pleasure and privilege to have Dr. Gotzaridis speak to us today. His topic is very interesting, blunt trauma and the consequential large vertical macular hole. So without further ado, I invite Dr. Gotzaridis to begin his presentation.
Hello, good evening, good afternoon. Thank you for inviting me to your great webinar meeting. I'm really delighted to be here with you. I would like just to spare one moment with you in order to find how do I'm going to share the screen with you. It has been minimized. Let me open it. I'm going to present a case, which is a blunt trauma case in a young gentleman. I really apologize for that. Maybe if we pass to the second, let me find this one. Resume. Now, I have some difficulties to upload my.
Okay.
I have some difficulties, so I need to leave the Zoom and come back to you again. Sorry about that.
Not at all, sir. We will look forward to your rejoining and your presentation in a short time.
Okay. Thank you.
So then it's my pleasure to invite Dr. Himadri Chaudhary, who is also a co-moderator in this session. I invite him to introduce our second speaker of the session, Dr. Himadri.
Am I audible?
Yes, Himadri, please go ahead.
We have with us Dr. Ashraf Sharawi from Cairo. He will be presenting.
Yes.
He will be presenting. Be aware.
It's my pleasure.
Yes, sir. Go ahead.
Okay, I'm going ahead. Can you see my screen now?
Yes, it's visible.
Okay. It's my pleasure this afternoon to be sharing in the Ophthalmological meeting and the eyesight day. I will be presenting a case about once retinectomy, always retinectomy in the other eye. This is a case of 63-year-old male patient presented 4 years ago with right pseudophakic retinal detachment with PBR grade D2 with a vision of hand motion to PL with the eye very hypotenuse. A vitrectomy procedure was planned. The retina was extremely shortened and the retinectomy was performed 180 degrees and silicone oil was injected at the end of the procedure. And this was the presentation at the start, multiple horseshoe breaks at the area of the vitreous base with extreme PVR to the retina and a closed funnel, a PVR grade D2. The procedure did start by vitrectomy, and as you can see, the eye was hypotenuse. There was difficulty in the introduction of the trocar and the vitreous cutter. Bimanual surgery was used to tackle this case, trying to dissect the vitreous from the retinal surface, attacking all the epiretinal membranes and all the vitreous on the surface of the retina. And at one step in the case, we did highlight the attachment of the vitreous by using intravitreal triamcinolone, which is a low visual aid tool for the surgeon. And as you can see, there was a very small, tiny break on the nasal side of the retina. And on the temporal side, there was multiple flap tears trying to dissect the attachment of the vitreous using the triamcinolone and then injecting PFC to flatten the posterior vitreous and to open the funnel, and using bimanual technique to dissect the vitreous up till the vitreous base. And there was a retinal cyst indicating long-standing retinal detachment, which I did excise so that it helps in reattachment of the retina. After complete dissection of the epiretinal membrane, the retina was still shortened. It didn't conform to the retinal surface, to the eye wall. So I have to inject PFC and perform an inferior 180-degree retinectomy. And as I injected the PFC did go back under the retina and elevated the retina, indicating that the retina is still shortened. So I have to remove this PFC bubble again, and then extend my retinectomy and re-inject PFC, and finally the retina was flattened and confirmed to the eye wall. After flattening of the retina, I did apply 2 to 3 rows of endolaser to the site of the retinectomy, and almost 360 degrees all around the periphery of the retina. The retina was flat at this point, and performing the endolaser, as you will see in the next frames of the video, injecting more and more of PFC to flatten the retina and to highlight the extent of the shortening of the retina. Now, the retina is almost completely flat. Application of 2 to 3 rows of the laser to the area of the retinectomy, and again to the area of attached retina, so that to guard against future reopening of the breaks. Finally, PFC silicone oil exchange was done, and the very end drops of the PFC was removed. And this was the post-operative appearance under the silicone oil 1 month following the surgery. I did realize that the retina was flat, so I did go back in 3 months duration to remove the silicone oil, which was removed completely, and I did apply more laser to the edge of the retinectomy to be sure that there is no possibility of recurrence of the detachment. Again, the silicone is completely removed, and application of more laser to the retina. Actually, this was the post-operative appearance of the case 4 years later. The primary surgery in the right eye was done in 2019, and this is the picture 2023, so this year. And as you can see, the retina is flat. The retinectomy edge is very well closed with heavy laser to the edges. There was an epiretinal membrane on the surface of the macula, but the visual acuity was 0.2, and this was very satisfactory for me. I didn't think about going back again to surgery to remove this epiretinal membrane. And again, this was the OST of this right case 4 years later, and there was an epiretinal membrane, some folding of the fovea, but I thought that re-intervention won't cause any visual improvements. The left eye, actually in July 2023, dropped in visual acuity, dropped from 0.8 to 0.2, and actually this was the birthday timing of my big son, so it was a very happy instance to find a macular hole, and at the same day the birthday celebration of my son. And as you can see, this was the size of the macular hole and its full thickness. So I decided to go for surgery. A vitrectomy procedure was decided with peeling of the posterior hyaloid, island flap, sulfa hexafluoride, non-expansile 20% was used as tamponade. And this is the video of the surgery of the left eye after highlighting the vitreous attachment using Kina quartz and removal of the whole vitreous. And as you can see, there was residual.
Dr. Ashraf, we are unable to hear you. Dr. Ashraf, we have lost your video as well. Dr. Devendra, is he audible?
No, I'm not able to get audio from sir.
Maybe we can wait for a couple of minutes and then move on to the next speaker.
Sure, Himandri, whatever you feel.
We can get in a couple of questions till he comes back. Dr. Stratus, would you prefer a scleral buckle in cases where we have to do an inferior retinectomy?
Well, if I do inferior retinectomy, I don't place any buckle. If I have a severe PVR case, I would prefer to have an encirclement 360 buckle just to support the periphery and the shortage of the ischemic and PVR retina.
Thanks a lot.
If you would like me, I can start with my presentation if we have problems with the connection.
Are you ready, sir?
I am ready, yes.
Okay, then we can go ahead with your presentation. We seem to have lost Dr. Ashraf.
Okay. Now, as I told you, it's a blunt trauma which created a large vertical macular break. I have no financial disclosures out of this presentation. It's a male, 17-year-old young gentleman who had a fight 10 days before he appeared to my office. And he had a fist into his eye that's created a large vertical tear. The RPE was damaged too, and his vision before the trauma was 10/10, and after that it was counting finger. He has seen other surgeons who all of them suggested no surgery to be done. This is the damage. As you can see, the large break just temporarily to the foveola. You see the RPE damage, the sclera, the white part of this macular damage, it's the sclera, the appearance of the sclera, the separation of the RPE, and in these areas, the SRF, the subretinal fluid, started to accumulate and to detach the retina. Here is the OCT in several places. The central cut shows the foveola, it was damaged, although has not detached, but the severe trauma of the RPE that goes straight to the sclera. A superior cut, you see the SRF accumulates on the nasal part of the foveola. The same, an inferior cut also presents SRF in the area there. So the big question is, what should we do in this case? Should we apply just laser all around, burning the macula but keeping the retina attached? Should we do vitrectomy, laser and gas, or laser and oil? Should we put a buckle in the macular area, or just only buckle, or vitrectomy buckle and gas or oil? Finally, I decided not to do this, which is, it was the easiest thing to do after doing nothing, just laser, because if you can see here, there is an appearance of untouched foveola, and applying laser, the scar, the burn of the laser would damage the foveola. I decided to go for vitrectomy. This is how the case starts. Inferiorly at 6 o'clock, the vitreous had already separated because of the trauma. So it was really much easier in a young patient of 17 years old to create the posterior vitreous detachment from the periphery initially, and then very easily and very carefully and meticulously to separate the vitreous from the area of the macula in order not to elevate the retina around of the retina hole, retina break. So continue with the vitreous separation inferiorly, because I had a lot of vitreous to work with there easily and carefully, and now it's the peel of the posterior vitreous phase. I go to the nasal part to remove all this vitreous, and then to the superior part at 12 o'clock, and gradually, little by little, over the disc to go to the temporal side. Fortunately, there is no any traction on the damaged retina. And now the next decision, what should we do? I decided to treat it as a very, very large extended macular hole. What does this mean? That means ILM flap over the damaged tear. You can spot here the healthy foveola. So big pieces of ILM folded over the break. From each side. This is the nasal part. And then I go from the temporal side also, create other flaps, extend the ILM peel. The plan was to extend as much as possible the ILM in order to release the traction on the retina and to leave the two edges of the break to come close and to behave as a macular hole, actually. I injected Kenalog in order to identify whether there is any residual vitreous on the surface of the macula that would create difficulties and provide stiffness to the retina to close the break. Finally, no any residual vitreous remained on the area, which was good. And once I aspirate everything, I went to the fluid air exchange. I drained as much as possible. with a soft tip cannula to the edges of the brake, not to the central. I didn't want to touch the macular area, so I did go to the edges of the brake, inferiorly and superiorly, in order to aspirate as much as possible subretinal fluid, and then applied laser only to the two corners of the brake. I didn't apply on the central part of the brake, just to the two corners, a very light whitish burn, very, very light. Finally, the case was finished with subconjunctival antibiotics and injection inside the eye of 2.5 mils of pure SF6. The patient had been asked to face down for 10 days, and this is the appearance before and after the operation. You see the light laser on the top and on the bottom, how it was before and how it is after the operation. And you see the subretinal fluid before the operation in the OCTs, how do they appear, and the huge gap in the macular area, the breakage of the RPE, and this is after the operation. The RPE came closed, the hole was closed, SRF disappeared, and 20 days after the operation, the vision improved to 0.5, an amazing improvement of the vision. The retina remains flat. We had a myopic swift of the macula of the eye. Or before the trauma, he was emetropic. After the trauma, he is myop, 2.5 diopters, because the axial length became longer because of this deepness of the posterior pole, which is acceptable. The patient is happy. The surgeon is happy. So thank you very much for your attention. And I'm open to have any questions from your side.
Wonderful, wonderful presentation, Dr. Gonzalez. I have one question. Would you prefer using PFCL to peel this case, to peel the ILM in this case?
Actually, as you have seen, it was really very easy to peel the ILM. I didn't have any difficulties to peel. There wasn't any traction on the macula, on the retina around the macula. The retina wasn't mobile, so I didn't need to have an agent to stabilize the area. On the other hand, I'm not a heavy liquid lover and user. I try to use it as less as possible, only in giant retinal tears cases in order to unfold the retina. In all other cases, I try not to use it because I'm afraid of the small bubbles behind the retina. And here we had a very extensive break. So it was really very easy, one small bubble to go behind the retina, and then all these beautiful results to be damaged.
Thank you, sir. Maybe we can just finish Dr. Ashraf's case. We had reached up to the macular hole in the other eye.
Okay, can you see my screen now?
Not yet.
Okay, just a moment. Hello, can you hear me?
Yes.
Okay. Okay. Somebody is blocking my share. Somebody is blocking my share.
Can the tech in the hall please look into it? The share is not happening. We are getting a message that sharing has started, but the screen is not visible yet.
Okay, I'm trying to get back with the share, but
okay, in the meantime, that we can move on to the next case.
Okay.
Next, we have Dr. Miriam Abdullahi. She will be presenting pediatric post-trauma retinal redetachment. Dr. Miriam, over to you.
I think you've got that slightly wrong.
I think it's Dr. Najjar.
Next talk is by Dr. Noor, who's a professor of ophthalmology, vitreoretinal surgeon at New Retina Clinic in Istanbul, Turkey, and she's going to be talking about a case of pediatric post-trauma retinal detachment. Please go ahead, ma'am.
Thank you. It's my pleasure to be here in this meaningful day with all my colleagues who struggle for preventing loss of vision and for gaining as much as vision we can. So maybe Ashraf is started screen sharing. Does he need to stop it so that I should share?
Yeah, I'm trying to stop it, but I don't know what's going on. Is it stop now?
Okay, I try to share my.
Yes, we can see your screen, ma'am.
Okay, and maybe I should make them whole. Okay, is it okay now?
Perfect, perfect.
Thank you. So yes, this is a large title with a redetachment in a young pediatric case with a blunt with an open trauma. So here's the case. He's a male, 9-year-old, presenting to me, but with a history of, at 1.5 years old, in the right eye, he has an open lobe injury cut with a broken glass. And then he has 2 times operated, one with a buccal and a vitrectomy, and the second is another vitrectomy, as with the history. And at the end, the silicone oil was removed. And the epicrizal operation notes, I could see that, I could find rarely that documentation, but I was lucky the patient had that. So the posterior hyaloid was separated. The surgery was done with a colleague that I know that she's a really experienced surgeon. So, and at presentation, what I see was the visual acuity was low already, but decreased a bit, as the mother says. It was like hand motion, and it is prophytesic and with aphakia, and the pupil was very small with synechias. I could start to see that there is a retinal detachment, but it was very difficult to examine because the pupil was really small. So we discussing with the mother and the parents and all together, vitrectomy is suggested without any visual hope, but maybe save the eye as much as we can. So here is the surgery. I should stop here. Just a minute. Sorry. So I should be able to, okay. Sorry, now I could that. So this is the eye starting from at the beginning of the surgery. As you can see, the pupil is very retracted, and then with the anterior synechia, here we can see the corneal opacity with the entrance side, the cutting side of the cornea, and there was the anterior segment was really flat. So I started to blunt dissection with the viscoelastic, the blunt dissection of this synechia. I just tried, but see that it was really very harsh, hard to remove them, open them. So I, what is it? I don't know. Sorry, I will fix it. So I have to do it like this, I think. Somehow I shouldn't touch the screen. Okay, so I move on with the iris retractors. I take out memories, and now I can see the full picture that the retina, as you can see, is totally detached. It's a revitrectomized eye. I start with the triamcinolone, thinking that maybe any vitreous, residual vitreous, or any membranes on top of the retina. And I didn't see this macular hole. This large macular hole was a surprise for me, like 1 disc diameter because of the traction. And I could find hardly any preretinal membrane, any vitreous with the triamcinolone, no staining at all. So I go on with the dual dye, with the double blue dyes, and with the large macular lens, contact lens, I try with the different forceps to try to find any membrane and peel any membrane, if any, going from the preretinal until the other side. So I'm not convinced that there is no membrane, but I could find hardly nothing at all. I struggled for some more minutes that I didn't show. At the end, at this moment, I think that, okay, anyways, I can do a 360 retinectomy to at least reattach the eye. So I go on with the diathermy and then the retinectomy. But I'm going very slowly and slowly checking at the back of the retina if there's any subretinal, and there's only then here, as you can see, that I can see something like a plan that maybe there's a preretinal membranous thing on top of the retina. And so as you can see, as I find this plan, and it was not so maybe bimanual maneuvers, I could have done the bimanual, but with the enthusiasm, I think I used with the light pipe with the bimanual maneuvers, that I could see that with the, I like the serrated forceps with a long neck, that it's really powerful. And then it was really not difficult to peel these membranes. I have already planned the 360 retinectomy. And then as I can see now that the retina is really very, the surface was really clean looking, and it is relaxed and it is attaching now, as you can see, on its own without any heavy liquid. So I move on with the injecting heavy liquid, and then to go on with the 360 retinectomy to move forward with retinectomy. Sorry for this. I think I'm around here. Okay, I won't touch again. So as you can see, and then after just cutting before the cutting glass edge, I go on with under heavy liquid again. I can see that the retina is really relaxed now. I inject more heavy liquids and then complete the retinectomy 360 and go on with the peripheral retina. There was some areas already retinectomized, I believe, but I tried to clean as much and attach with a very heavy laser. So I try to remove as much as the retina I can in the periphery, just to leave a large amount of gap in between the retinectomy eyes and retinectomy sites and the other eyes, and also remove all hemorrhage that we don't like to any residual hemorrhage. 360 endo laser, and after that I check for the large hole that I can see the edges are relaxed, even though there's a cystic appearance that it has gone away even at the temporal area of the macula. So this is under the heavy liquid. I go on directly because it was a very large hole. I just want to see, because this is the era, remember, that before any retinal autografting or amniotic membrane era. So I have to touch, but stop. So I just could see that at that time, what I did was under the heavy liquid, just go into the edges of the hole, not into, but under the heavy liquid, not touching the edges and the RPE, and aspirate the submacular fluid as much as I can. And after that, I waited at least, I get out of the eye and waited for maybe at least 5 minutes to all the liquid to come to the periphery and whole dryness of the eye under air, as you can see. And I can see that the hole is closed. So I go on with the silicone oil, 5,000 centistokes. And you can see we sutured all the retinectomies, sclerotomies. There's some, if there's any, just in case there is a silicone oil coming into the anterior chamber, I remove one of the trocar open, then the excess silicone goes out. So this is the end of the surgery. And the vision increase, as you can see, there's the OCT images of the eye. It is attached totally, but with the silicone oil still inside, because the intraocular pressure is not so high enough again. The vision increased to 3 meters counting fingers, like kind of ambulatory vision. And there's, you can see, but there is a fold in the temporal area, we can say. And the eye was stable. I could follow for like 2 years of this child. But then they moved to another city, a far city. But every year I ask for how is he, and then he goes to university clinic there. And this is the photograph of the eye. He's a beautiful child with, you can see still the cornea is clear at the central area. And the vision was the same, like, and the retina is attached. So they follow and they say that, okay, from time to time, he's under periodic follow-up. So this was my case. So take home message. I will state, as we all know, the posterior hyaloid is really difficult to separate, especially in pediatric cases. And as young as, especially in young eyes, in younger eyes, like 1 year, 2 years, it's really harder to, because of the vitroschisis. And there's some layer left, for example. If a layer is staying there, so it causes to the retinal redetachment. So even as a note, that we can state that we can think that, okay, I removed the posterior hyaloid, but sometimes it may not be so interestingly in the pediatric eyes. So, and secondly, what I learned from this case is the pigmentary changes that we can see, like in RP changes of altogether. I was vigorously searching for any pre-retinal thing, but I could not. Even there's some glistering appearance of the retina. The retina was really very thick and elastic kind of, and remember that there's no staining with the triamcinolone. So if there is a layer left, it doesn't stain. It becomes in time, especially in the young eyes, it becomes like a membrane, and then it doesn't stain with the triamcinolone. So also pigmentary changes can be a suggestive of preretinal membrane, thick preretinal membrane. So in this case, the large macular hole, if the relaxed edges, drying a couple of times and waiting 5 minutes at least, drying, total drying, and with non-contact drainage of the subretinal fluid, especially under the heavy liquid, may close the hole, as we can see here. And especially in this meaningful day of the World Sight Day, in pediatric cases, like in this case, for example, we were not waiting for so much vision, but protecting the globe is worth giving the chance for a surgery in a young patient. So I thank you again for all your kind invitation and all of my colleagues' nice talks. Thank you.
Talk, ma'am. I completely agree that it's definitely worth taking a chance in these post-trauma pediatric eyes for whatever it's worth. And the way you managed it, it was very well done. And I can't think of a different way how I would have tackled this case as well. Thank you for that, ma'am.
Thank you.
Can you see my screen now?
Yes, your screen is visible. Yeah.
Okay, now this is the left eye, which had developed macular hole in 2023. And I start by highlighting the vitreous using Kinacort. And I removed the whole vitreous and trying to use the Tano scraper and the polisher to remove all remnants of the posterior hyaloid. And then I stained the ILM using BBG stain and created a flap using a Tano scraper and used the ILM forceps to fold the flap inside the hole. And as you can see, now the flap is created using the Tano scraper. And in a second, I will use the forceps to fold the ILM flap inside the hole. Then when I finished with that, I did inspect the periphery of the retina, as you are going to see in just the next few minutes. And I did found multiple horseshoe breaks all through the periphery of the retina, to which I had applied endolaser and then replaced the fluids with sulfur hexafluoride non-expansile concentration, and the patient was sent to have prone position for a week following the surgery. The flap is being placed inside macular hole. And now going for the periphery. And as you can see, multiple large horseshoe breaks as what was seen in the other eye of the same patient 4 years ago. Endolaser was applied and the gas was replaced. The patient in the post-operative period showed flattening of the retina closure of the macular hole. However, 1 month, around 1.5 months following the disappearance of the gas, there was recurrence of the detachment, a detachment which did reach the macular area. And this is the scan showing subretinal fluid. So the patient has to go back to surgery. And as you can see, there was extensive subretinal proliferation with the fold extending to the upper nasal area, indicating that there is maybe a sclerotomy related retinal break in the upper nasal area. Again, vitrectomy, trying to clear any remnants of the vitreous base. And as you can see, there was extreme subretinal proliferation. So I have to resort to a retinotomy in the upper nasal area after removal again of any residual vitreoskisis or vitreous attachment to the retinal surface. And as you can see, the retinal breaks were closed by the previous end laser. Now creation of the retinotomy and introduction of an end gripping forceps through this site of retinectomy and excision of the subretinal proliferation, extending again the retinectomy so that I can get all the subretinal proliferation from the underretinal surface. And I was possible to do that. Now perfluorocarbon is being used to flatten the retina, bit by bit injection of perfluorocarbon till the retina is completely flat. And as you can see, the macular hole case in which the macular hole is closed turned to a PVR case because of a small sclerotomy retinal break. Now injection of more and more of PFC till the retina is flat, application of laser to the edge of the retinectomy, replacement of the PFC with silicone oil. Now, this is the post-operative appearance, a mosaic white field, a picture of the case under silicone oil. And as you can see, the nasal edge of the retinectomy, the retina is flat, as you can see, under the effect of silicone oil. I had performed OST on the patient, and the retina, there was some residual subretinal fluid under the fovea. This was 1 month after the surgery, although the retina appears to be completely flat. Again, the OCT showing some areas of subretinal fluid and some areas there is no fluid in the subretinal space. Now, the case had taught me that facing complication in the first eye, expect complication in the other eye. Vitrectomy and eye lamp peeling is an efficient way to close macular holes. As you can see, the macular holes were completely closed, although the retina was detached due to a sclerotomy-related break. Examination of the peripheral breaks during vitrectomy is a mandatory step, especially sclerotomy-related breaks. Silicone oil removal is a major surgery, and all precautions should be taken. Residual subretinal fluid may be present even in the presence of a completely attached retina. Retinectomy is not always associated with poor vision. Actually, this patient in his right eye, I had achieved a vision of 0.2, which is the best vision I had achieved in any retinectomy case in my career. Now, my question for the panel, do I go for silicone removal in the second eye while there is still subretinal fluid in the left eye as had been shown by the OST, or I should wait for removal of the silicone till this subretinal fluid is cleared? And thank you from Alexandria, Egypt, with the beautiful Mediterranean Sea. Thank you.
Thank you, Dr. Ashraf. It was a really, really interesting case with lots of ups and downs. Dr. Noor, would you like to take the question?
Okay. But I missed maybe how many months old is the surgery now? Silicone oil inside.
It's actually the surgery was around the birthday of my oldest child. So it's in the, July the 8th. And now we are on October. So it's around 3 months now.
Yeah. So depending on the situation, I'm not afraid of silicone oil in the eye too much. It can stay more because if you are still having some subretinal fluid and the second eye is also a bit, not easy going. So I think I would wait, Ashraf, until 6 months. We can wait for it. And seeing the patient maybe every month, for example, it won't emulsify in this period, I think. By the way, it was 1 centistoke or 5,000? 1,000.
It's 1,000 centistoke. I usually use 1,000 because eventually I'm going to remove this silicone oil. So I don't put 5,000 on occasion that I'm going to leave it in the eye. And as you can see in the color composite picture of the left eye, the retina is completely attached. But on the OST, there is subretinal fluid in some areas.
Maybe I may not follow it correctly, but there was some bleeding, or it was not pure, very relaxed retina. I think still not stable.
I don't. No, there is no bleeding because this is an SLO picture of the case, and the SLO have some artifacts in the color coding, so it's not bleeding. There is no bleeding. It's not true color of a normal flash camera. This is an SLO picture.
Okay. But anyways, that's why maybe we do something differently. 1,000 stoke, I guess, emulsifies even in 2 months, for example. So that is my at least maybe 5 years now that I inject. Whenever I inject that silicone oil, I inject 5,000. Anyways, I will remove it, but the machines now are really very fast and effective aspiration, so you can remove it not so longer time. So that is my way of thinking. But 1 centistoke, that I would see the patient maybe every eye, 1 eye apart, and then 1 month apart. Sorry for my Turkish, and then I could decide. Maybe not now.
Okay, thank you for your comment. Again, thank you for your nice presentation.
Thank you.
Thanks a lot, Dr. Noor. Maybe we can move on to the next presenter. We have with us Dr. Carlo Nasol from Philippines. He'll be talking about surgical thrills and spills, a surgeon's guide to retinal misadventures.
Okay. Hi, good evening, good morning, or good afternoon to everyone. I am Dr. Nasol from the Philippines. So let me share my screen. Just a minute. Good evening, everyone. I am Dr. Carlo Nasol from the Philippines. For tonight's topic, I'll be lecturing you about surgical thrills and spills, a surgeon's guide to retinal misadventures. I have no financial disclosure or conflicts of interest with the presented material in this presentation. As a quote, true teaching cannot be learned from textbooks any more than a surgeon can acquire skill by reading about surgery. Let us first define what is a misadventure. A misadventure is a very unfortunate incident, or in medical terms, it refers to personal injury or adverse reaction occurring as an unintentional result of surgery or other medical treatment. As we are surgeons, we always enter this retinal arena. Our adversaries are usually blood, hypotony, PVRs, machine issues, trauma, re-op, later referrals, and a lot more. So I will be discussing to you about a few of the adversaries that we usually encounter as a VR surgeon. One of the things that we do happen, that we do surgery do a surgery about is blood. Blood is one of the most common, and still we have those very thick vitreous hemorrhage even after we inject your anti-VEGF, and then after 20 minutes of continuous surgery, the media is still hazy. After 40 minutes of continuous AFX, and after a third or fourth area of air fluid exchange, and even with shield BSS, the media was still clear. Let's now go to a different portion of blood. There are a few times that when you do laser, very hard lasers, over retina and over a vessel, it usually is bloody. As you can see here, intraop subretinal hemorrhage secondary to excessive lasers. You can see here, there's this large subretinal hemorrhage secondary to a laser. What we usually do is just increase the intraocular pressure and just wait a while. When everything is stopped or tamponed out, you can now continue with the laser after draining. So what I usually tell my fellows, when you do laser, look at the area where you're aiming your laser at. Laser the areas where it's devoid of blood vessels, so this event will not happen. Again, how about in ILMs that have membranes over? This is a fellow case. So we've called it bloody ILM, but you can see here one of the fellows is trying to peel the ILM, and then this membrane goes out. So what I usually tell my fellows is, hey, do an air fluid exchange and wait for that to stop. Don't pinch anymore, and then just wait for it to become stable, and then you can do your surgery after everything is okay. Next, in patients who are post-GDD or post-TRAB patients, hypotony is one of the things that we want to watch out for. Look at what is one unfortunate instance where we were placing the second trocar, the infusion popped out. When we placed it back and we took a look at the retina, look at the massive choroidal secondary to the closed TRAB and secondary to the removal of that infusion line. In patients who have giant retinal tears or like chronic retinal detachment, the eye is very soft. You can see here, we were trying to place the first trocar here. As a remedy, we asked the fellows of the surgeons to inject BSS on the retina while placing the trocar so the eye will be firm. You can see here, on the large retinal detachment, usually the eye will be very, very soft. Next will be visibility. When you're doing a surgery, vision is the most important thing. How about in patients who have infections? In a patient with endophthalmitis, the first thing that we should do is remove the fibrous material in the AC, wash it out, and then try to do the checktomy. You can see here, even in a very bad corner, you can still see a little bit, but it's very, very, hard for the VR surgeon to see what we're really doing. Next, in post-cataract patients or pseudophakic patients, IOL fogging is not one of the most annoying things that we experience in a VR surgery. You can see here, it's a post-pseudophakic eye with a very large retinal attachment. And then while doing a vitrectomy, everything's all clear. And then when you go to air fluid exchange, you can see here that everything fogs up. The IOL keeps on having those moisture issues. Even if you wipe the IOL with your DSS or your viscoelastic, it's usually very foggy. And these are the cases that we really don't want to see during the OR. With the advent of the 3D machine, visibility under vitrectomy with the pseudophakic eye would be much easier now using a 3D machine. The 3D acts as a third eye for us. We are surgeons, so we are very lucky in an age that we are very lucky now that we have a 3D machine. So we try to push it further. How about in a patient who has a cataract? And the 3D machine can still do it. So in patients, when you do air fluid exchange, you can see here, vision is still quite good in comparison to your IOL. Now, moving on to different drill. In flare buckling, this usually happens when the suture is too deep. You can see uveal tissue with sort of like subretinal fluid coming out of that area. So what we did was cauterize it, and then we usually do a cryo over the area where the needle passed through. As retinal surgeons, we are always referred with patients who have chronic retinal detachment, patients who have PVR, and here's a simple case, like, for example, this is supposed to during a vitrectomy, as you can see, it's very small hole. So once you do an air filtration, that hole enlarges will become bigger. This is one of the simple cases. I'm now going to show you a more complex case. You can see here, during a vitrectomy, watch what happens with doing air filtration in a very short eye. Retraining. Everything lifts up. So that's one of the signs of a very shortened retina. So how about a combination of a choroidal and a subretinal hemorrhage? This can happen in cases who have glaucoma, we have patient trauma. So what we do is like still do a vitrectomy and then remove the subretinal hemorrhage underneath that choroidus. That choroidus will act now as a sort of a buckle for us. So it's a simple thing. We convert into a retinal attachment, we drain the subretinal fluid, remove the blood, and then add up a little bit of a laser and a silicone oil just to make the eye flat. And then we watch out for any areas of hypotony post-op, and additional lasers can be given again. And moving on, how about trauma? Trauma is one of the things that the VR surgeon is happy about, because in trauma there are no rules. Like for this example, this had the trauma, the medial rectus is now impinged on the side with a closed funnel, semi-closed open funnel retinal detachment with massive PVR. So what we did, we released the retina, as you can see here, and then removed all of the PVR band, removed the subretinal blood, and then we tried to relax as much as we can. With this technique in trauma, after releasing all the retina, we try to open up and see if the eye can really see, or is there any hope. We use perchlorone, as you can see here. Moving on, after removing all the band, okay, the macula can be seen. So it's sort of like it's a good path for this patient. So the macula can be seen, and then after removal, we did laser. Removal of subretinal bands, we did laser, and then injected silicone oil. You can see here. Next, reoperations from different surgeons. We do usually get referrals from different hospitals, so it's sort of like a second try. This is a case of a subretinal silicone oil migration secondary to a re-op from a different surgeon. They did the scleral buckling, vitrectomy, and the silicone oil. Eventually, we went into PVR. So again, they asked for help to repair the retina. So what we did, we removed the silicone oil, tried to release all the bands, and then released the subretinal silicone oil that's been trapped in that large hole. So after removal of the bands, we did an air fluid change. There was a little bit of shortening. And then afterward, we did the relaxing retinectomy. As you can see here. We did a laser and then injected silicone oil. So re-ops is one of the things that we do really get. And for my last case, this is a case of a macular hole, retinal detachment, secondary to a PVR, and then it has a new hole at 6 o'clock. And again, this is a post-vitrectomized eye secondary to a rheumatologous retinal detachment, which developed into a macular hole. and another hole at 6 o'clock. Sadly, the silicone oil was trapped underneath the retina. Okay, so you can see here, there's two main problems. So the first thing we do, we remove the silicone oil, PFCL, and then we peel the ILM under PFCL. We did an inverted flap technique to close the macular area. We left that PFCL on the macula while we were fixing that trapped subretinal oil. So we did a large retinectomy to release the oil. Fortunately, there was shortening of the retina, so we had to do a larger retinectomy to release all of the tissues on the exterior. After releasing everything, we did laser. We added more perfluorocarbon just to flatten out the retina, as you can see here. So we now have a flat inferior retina and then a closed macular hole. So for take-home point, if you haven't got any complications, you haven't done enough. Always record your cases and review and learn from it. Never stop learning because each case is different and the best teacher is experience. What I usually tell my fellows is a smooth C never made a good sailor. So I'd like to thank my fellows, Dr. Jaitu and Dr. John Chua, for all the videos. We have compiled a lot of videos for everyone. So I'd like to thank you on behalf. And again, I'm Dr. Nasal from the Philippines, and thank you for listening.
Great presentation, Dr. Carlo. So thanks for covering a whole range of complications and teaching us a lot about pretty much every aspect of VR surgery. Personally, from my own experience, I'd just like to ask you a bit more about your experience with endophthalmitis and how you approach early cases. Is vitrectomy with insertion of silicone oil like a primary approach you follow for most patients? Or do you go with a wet tap and inject and like a delayed vitrectomy for those patients?
For endophthalmitis, we don't follow the old ruling. So we do early vitrectomy for almost all of the cases now. We don't follow the EVS anymore. So we just do a vitrectomy and injection of an antibiotics. Silicone oil, we rarely use that. If we do get a iatrogenic break, that's the time we only use the silicone oil. But we're very careful when we're doing the vitrectomy for endophthalmitis.
Right. And would you treat a panophthalmitis patient in a similar fashion as endophthalmitis, or would you be treating them via a different approach? So if you have...
If panophthalmitis, I would have treated him systemically first, and then I would ask the others if they're brave enough to do the vitrectomy for the eye.
All right. Thank you so much. If we are ready to move on to the next presentation, or we're open to other questions from other colleagues, we'd love to hear from you.
Thank you very much.
Thank you.
I think we'll move on to the next topic because we are running slightly short of time. And we have with us Dr. Francine Vega from Brazil. And she's going to talk about our favorite topic about diabetic vitrectomy. So over to you, Dr. Francine.
Hi, nice to see you. Thank you for the invitation. It's a very honor to be here talking to you. May I share my screen?
Go ahead.
Okay. Do you see my screen already?
Yes, we can see it.
Okay, that's it. So I'm going to talk about surgically challenging cases, and we all know that diabetes mellitus is an ophthalmology problem that we have. These cases are growing year after year, and we have a lot of deaths globally, and China, India, Brazil, and Russia lost at least 20 million productive years because of diabetes mellitus. So we have a lot of spending, and India especially is expected to overtake United States in the next years, in 2045, in number of patients and spending. So you and I and we in Brazil have to be prepared for this increasing cases. And you also know that we have a lot of diabetic retinopathy, and this has increased 150% in 30 years. So 1 billion of visual disparity and blindness could be avoided. And so we have cases that are simple in diabetic retinopathy, like this one, when you have to do a combined surgery with cataract, removing cataract, IOL, and we should not use special IOLs in those cases because we don't know how are going to be the vision. And we always use anti-VEGF prior to surgery to avoid bleeding. And in this case, the person has vitreous hemorrhage. We are only removing the hemorrhage and completing the photocoagulation. And we finish or under air or under gas or with PSS. It depends on each case. But also we have cases a little bit more difficult like this one, when we have this tabletop retinal detachment, and now you see that we have all the fibrovascular tissue taking the retina over and detaching the retina, and we start removing the vitreous from the base and doing a vitrectomy and liberating all this circular fibrovascular tissue. And now I'm trying to use a probe to find a plan, to find a space to start the surgery. I could not do it, so I tried with the scissors, but then I changed to chandelier and both hands to do by manual because I really could not find a place to start. So here I'm removing with the scissor and forceps. I'm trying to dissecate this fibrovascular tissue from the retina. You see that we have a lot of bleeding. It's very difficult here. I put the pressure very high to stop the bleeding. But when you are dealing with this case, you see there that we have tear here. And when you use perfluorocarbon in those cases, the retina is very thin, is very ischemic. And if you have perfluor under retina, it can complicate even more this case. So I just try to do it with high pressure, and we have to take care because if you have high pressure for a long time, also you can damage more than it's already damaged the optic nerve, but we have to do this. So at the end, we did their fluid exchange and we finished with laser and silicone oil. And this patient, he has hand movement at the beginning, and the final visual acuity was counting fingers 1 meter. So it was not the best result, but at least he's not at the dark, and it was his single eye. And also we have this other case just to illustrate that, sorry, sometimes when you use anti-VEGF and patient does not do what you say that she should do, things like this happen. As you see here, the patient had underwent to anti-VEGF 5 days before surgery. That's for the scheduled surgery. She didn't show up, and then she showed up only 20 days after. So that we have this very dense hyaloid, and the fibrovascular tissue has contracted. It was very dense, so I have to deal with all this hyaloid that I trying to find a plan, trying to liberate this fibrovascular tissue from the optic nerve. It was very tough. I had to put the vacuum high and to put the cut down to be able to remove this. And we have this tear, posterior tear, but it was okay also because it helped me to aspirate the blood that was under the retina. And then I deal with the traction, did the fluid exchange after, and the laser, and we finished under silicone oil as the other one. I really like to use silicone oil in those cases because, of course, our difficult case, you don't know if you can remove the silicone oil after. Retina can redetach, and that's something that we should think when we do this challenging case of diabetic vitrectomy. Here you see that the macula was flattened and the retina was attached, and the visual acuity was 20 under 400, but the external retina was not so nice. So we can discuss about technique, traditional or bimanual, and isolate or remove all traction. I prefer remove all traction, but sometimes the cases are very tough if we have to isolate the traction. gas or silicone oil, but in this challenging case, I really prefer silicone oil. And for take-home message and what I learn each day about those difficult cases is that diabetic retinal detachment are always complex. No case is like the other one. And if you do an anti-VEGF, maximum 7 days before, and be sure that the patient will come for surgery. If you have any doubts, don't do it. Expect or do it the first, perform it as in your first surgery and leave the patient to the last one, because it's interesting, but if you have at least 3 hours of anti-VEGF, it helps to stop bleeding during the surgery. You may use the pressure to your advantage, but take care of leaving the pressure for high as 60 millimeters of mercury because of time, and always have an endodiatomy on your hand and in the operating room, because if you don't, you may be in trouble. And peripheral can help, but be aware of tears in the posterior pole. And for me, how to avoid bleeding in this complex case after after surgery is to finish with anti-VEGF or TPA. We are going to have a little bit of hemorrhage in the silicone vitreous there with the silicone oil, but it's going with time, it's going down, so we have a clear visualization after. In our ideal world, what we should really do is to perform coagulation for proliferative diabetic retinopathies to prevent those cases. And sometimes contraindicated surgery does not describe a good surgeon when you really don't think that you could help. I thank my fellows, and I would like to invite you to our Congress in Brazil next year. And thank you so much.
Thank you, Dr. Vega, for that lovely presentation. I think if any of the panelists or the speakers have any inputs further to add on what Doctor has already shared with us. Yes.
Hi, very nice videos, Dr. Francine, but sometimes the second case with the tabletop really bled and it can cause coagulation during the membrane peeling. So we used to, before the VEGF era, I think, did you inject anti-VEGF in this eye, for example?
Yeah, we inject in all eyes anti-VEGF before surgery. The second case, the tabletop one, you mean?
Still, I mean, bled during the surgery, so it is very difficult. Yeah. So for the anti-VEGF era, what we used to do, and sometimes really I try to use, we put low molecular weight heparin in the fluid, like 5 cc fluid, like 10 milligram of it, and then until the delamination of all the membranes, we use it, because it may bleed, but didn't increase the bleeding too much. It's preventing the coagulation. And at the end, when we are sure that we remove all the membranes and even with the bleeding, but then we exchange the solution, infusion fluid, with the normal one without the heparin, and then continue after that. So postoperative hemorrhage was not so much as a complication that time in our hands. So sometimes, I just want to add it, sometimes rarely we may also, especially type 1, poorly regulated diabetics.
That's a wonderful tip, because that's my problem. I deal with so many difficult cases here in the public system. So I was planning, I talked to a person of the lab and said that, can we do some methylcellulose with anti-VEGF or even with TPA, because that way I could put it under the retina, find a place, put under the retina, wait a little, and then start peeling. But that's a good tip. Thank you.
You're welcome. Thank you.
I think we can take a screenshot as Dr. Noor has suggested, if we have no other questions.
Picture or screenshots, is it good?
If everyone can turn on their, yeah.
Or somebody else can do. 1, 2, 3, please smile. Okay, thank you.
Okay. So
Thank you, everyone.
Thank you, everyone. And it was really a great session and good to catch up with everyone.
Thank you. Thank you.
Thanks for the opportunity. Have a nice evening.
Bye.
Bye.